All right, so we continue with the chat. Okay. So we continue with the next topic, yeah? Can I know whether you guys still there? Okay. All right.
Yes, doctor.
Oh, thank you, thank you. Okay. All right, so sikit lagi. Pharmacogenomics in adverse drug reaction. Okay, so this is actually an important role in which we can actually prevent the drug adverse drug reaction, especially if the adverse drug reaction is life-threatening. Because you imagine if the patient, kita tak tahu pun dia akan dapat that side effect, that ADR, right? But we give him the similar drug that we usually give to other patients as well. But then tiba-tiba this patient admitted with severe rash, Stevens-Johnson syndrome, and then dapat complication, and then the patient dies from it. So you can imagine macam how macam nak cakap our role as a healthcare provider, healthcare professional, we put our patient first. So kalau lah kita tahu awal the patient is going to have that reaction, memang kita tak akan bagilah kan. But how are we going to know if we do not have the information to it? We don't have the way to know, okay? But now, with pharmacogenomics, there are pharmacogenetic markers that can actually predict some proportion or probability that this patient is going to have that reaction, so that we can actually stop the patient from taking that drug. Okay, we are actually saving the patient's life. Okay, so this is what I want to highlight to you, in terms of the ADR, because we are not actually looking at the effect of side effect yang biasa-biasa ni. Macam tadi kan, intolerable side effect apa semua, that one can cause quality of life change kan. Tapi this ADR itself, the adverse drug reaction ni, can actually cause mortality, can cause death. So that is even more bigger picture of it lah. So if you recap back your ADR, we have two types of ADR, type A and type B. Okay, you tengok balik you punya lecture pharmacology dulu, you ada belajar ke tak? Type A is related, kejap mana ni? Okay, and yeah. Okay, skip this. Okay, your type A type A ADR predicted from the pharmacology. Maksudnya from the pharmacology punya mechanism of action, you know already this drug is going to cause certain side effect. And you just have to mention it early to your patient. Ataupun, and also type A reaction is those related toxicity identified prior to drug licensing. Maksudnya the drug company tu before they register, dia dah masuk dah siap-siap dalam pamphlet, drug pamphlet. All these side effect kan, berapa persen apa semua. It is more common and it has low morbidity and mortality. Maksudnya it's just that patient tu tak boleh tolerate ke tak boleh tolerate lah. Okay. Whereas the type B reaction is not predictable, not related to pharmacology, not related to dose, poorly reproduced, and less common, and high morbidity and mortality. And kita tak boleh predict from the drug punya mechanism of action. And usually it's not related to the dose. Maksudnya dose yang sama je with the other patients. The usual dose that all other patients would get, but this particular patient might develop that reaction. Also high morbidity and mortality. So these are the enzymes and genes that are related. Type A is Sick enzymes because it relates to the dose tadi kan. So it relates to the serum level, concentration of the drug. Kalau patient tu poor metabolizer, ada accumulation and it cause more serum level is increased, maksudnya dia punya side effect tu lebih pronounced. Okay, so that's related to the dose, related to the metabolism. Also drug transport protein and NAT2 enzyme, which are also the involved in the mechanism. In the metabolism. Where else for type B reaction, it relates to HLA gene. Ini kita akan tengok nanti apa HLA genes. Okay. Okay, this one. Okay, for warfarin-induced bleeding, actually this is not so new. So we know already, I think dah berpuluh tahun dah, that warfarin can be, warfarin. Warfarin is the anticoagulant, and usually we monitor the INR. We monitor the patient punya effectiveness or the bleeding tendency with the INR reading, kan? But there is also a genetic marker in which can predict the variability in the warfarin therapy. And these genes are CYP2D6 and VCOC1 genetic polymorphism. And the studies had shown that CYP2D6 and VCOC1 polymorphism account for majority of the variability in warfarin therapy. Maksudnya, if you give 100 of patient with the same dose of warfarin, not all are actually having the same INR reading. And 40% of that variation comes from the genetic variation of CYP2. Sini bukan CYP2D6, CYP2C9. Okay, this is CYP2C9. So it comes from CYP2C9 and VCOC1 polymorphism. Okay, and another 50% is from age and BMI. So maksudnya nak cakapnya dia punya genetic variation of this gene is very important to explain kenapa 100 of patient ni dia punya INR reading lain-lain. Okay. And CYP2C9 STAT2 and STAT3 polymorphisms reduce the metabolism of S-warfarin to 12% and 5% respectively. Okay, if you remember CYP2C9, also STAT2 and STAT3 are the poor metabolizer for CYP2C9. VCOC1 also in this SNP increase the sensitivity to warfarin and reduce warfarin dose requirement. Okay, so okay, this is the result from GBOS. That's okay. Okay, so this is the forest plot. This is from the meta-analysis, in which, if you can see here, if the patient is having CYP2C9 STAT2 and STAT3 poor metabolizer, and you see here the black punya bentuk apa ni, macam diamond ni, it's shift to the right. Maksudnya, and you see here the odds ratio here, overall hazard ratio, 2.19. Maksudnya, if the patient is having STAT2 and STAT3 of CYP2C9, the patient is 2.19 times more likely to develop bleeding. Okay, ini ialah forest plot untuk hazard ratio of the bleeding tendency if the patient having this genetic variation. Kalau STAT2 sahaja, it's 2.56 times more risk to develop that bleeding. Ini pun kurang sahaja. Itulah. So these two important enzyme or genes for warfarin metabolism would be CYP2C9 and also VCOC1, also to it will increase the sensitivity of warfarin. So if we know earlier that this patient having poor metabolizer, so kita akan adjust the dose accordingly supaya patient tak dapat that bleeding. Okay, so that's the type A punya ADR. Okay, another one, type A ADR is also for codeine-induced respiratory depression and CYP2D6 ultra-rapid metabolizer. Okay, ultra-rapid metabolizer for CYP2D6, if you can remember ultra-rapid metabolizer, it is a multiplication of the SAR1, the wild type kan. Okay, can you read this case? I give you like 1 minute to read. Okay, dah ya? Okay, ini cerita tragis juga, tragis sekali because it involve an infant, okay, newborn infant, born after an unremarkable pregnancy. Maksud unremarkable pregnancy itu maksudnya tak ada masalah apalah. Maksudnya the pregnancy was going smoothly, delivered 3.88 kilogram, developed difficulty in breastfeeding and increased lethargy at 7 days of age. So after seminggu lahir, this patient, this baby have difficulty breastfeeding and increased lethargy. So at 11 days of age, he was taken to a pediatrician because there is concern about his skin color and decreased milk intake. Maksudnya tak feeding sangat. And then on day 13, ambulance team found the baby cyanotic and without vital signs. Okay, on day 13 tu baby tu dah biru dan dah have low pulse. Maksudnya baby tu dah meninggal, tak dapat diselamatkan. Okay, the resuscitation pun unsuccessful. Okay, after the postmortem, barulah they found out that the toxicology testing found a blood concentration of morphine at 70 nanogram per ml. Common concentration is 10 to 12. And also acetaminophen at 5.9. Review of medical record revealed that in the immediate postpartum period, the mother was prescribed Tylenol. So Tylenol is combination of codeine and acetaminophen, which is paracetamol lah. So initially she took 2 tablets twice daily, but she halved the dose on postpartum day 2 owing to somnolence and constipation. Following the development of poor neonatal feeding, the mother expressed milk and stored in the freezer. Analysis of the milk for morphine revealed a concentration of 87. Maksudnya also a very high concentration of morphine in the milk, in the breast milk. So what happened here is that, ada tak explanation here? So what happened here is that the mother was taking Tylenol, a combination of codeine and acetaminophen, and codeine needs to be metabolized by CYP2D6 to morphine. So codeine is a prodrug, morphine is the active drug. So that's why we see a concentration of morphine dalam badan baby too, because the mother is actually, it is known afterwards, if they do the genetic testing, the mother is actually poor metabolizer, ultra-rapid metabolizer for CYP2D6, and then the mother actually metabolized very fast codeine into morphine. So that's why the concentration of morphine is very high at the same at the certain time. And because the mother breastfeed, so the morphine is transferred into the breast milk, and the baby take the take the breast milk including the morphine. So that's why the baby punya blood concentration of morphine is also high. And also that's why it explains the morphine also present in the breast milk. So eventually the baby died because of respiratory depression from morphine toxicity, because the mother is having ultra rapid metabolizer for CYP2D6, in which it leads to faster conversion from prodrug of codeine to morphine. Okay, so this is a tragic case lah, which it leads to FDA drug safety communication, in which FDA restrict the use of prescription codeine pain and cough medication, tramadol pain medication in children and also in breastfeeding women because of the case. Okay, so sekarang dia dah tak recommended lah. And then the CPIC guideline also was being released about the use of opioids and also CYP2D6 genotype and phenotype. So also the same, dia punya phenotype is also the same. This one is a bit outdated. You follow the one that is that I gave in the previous lecture. That one is actually in 2023. So dia ada sama je, lebih kurang je. And the allele pun actually the same sahajalah. Okay, CYP2D6, we have covered this one. Okay, this one pun sama, repetition sahaja. But this is the recommendation from CPIC guideline. Maksudnya dia ada dah dia punya recommendation kat sini. If it's CYP2D6 ultra rapid metabolizer, so there is an increased formation of morphine, which leads to higher risk of toxicity. So avoid codeine use because of potential for serious toxicity. Recommendation is also strong. Okay, and normal metabolizer as well. We need to expect morphine formation as well, higher than intermediate. So also strong recommendation to use codeine label recommended age specific or weight specific dosing. Maksudnya we have to be very careful with the dose if the patient having normal metabolizer. And if the patient having poor metabolizer, avoid codeine as well, because it will be less converted into the active form. Maksudnya the patient might not get that effect. Okay, so that's specific recommendation. Okay, this one for tramadol. This one pun lebih kurang sahajalah. Okay, if it's ultra rapid metabolizer, also avoid tramadol because it will also be converted to active metabolite. Okay, next is isoniazid-induced liver injury and NAT2 acetylated. So this one relates to the liver injury or hepatotoxicity because of isoniazid treatment. Isoniazid is the TB drugs, okay, anti-tuberculosis drug. So if the patient is taking isoniazid, and this patient is having NAT2 slow acetylator, then this patient might develop liver injury. So if you look at the mechanism here, this is isoniazid. So NAT2 enzyme is important in the metabolism of isoniazid into non-toxic metabolite lah. Bukan non-toxic, maksudnya it leads to the metabolism of isoniazid into the toxic reactive metabolite, but then it will require further metabolism by GST and also NAT2 juga untuk jadikan toxic. Tapi if there is a low activity of NAT2 in the process of metabolism of isoniazid 2, then it leads to higher a higher level of toxic reactive metabolite. So the patient might get liver injury. So kalau kurang kat sini kan, NAT2 kat sini, it will convert this acetylhydrazine to the less toxic diacetylhydrazine. So kalau kurang NAT2 activity kat sini, it will be more of the toxic reactive metabolite in which it will cause liver injury to the patient. Ini ialah dia punya phenotype, rapid acetylator, STAR2, STAR4 and STAR12. Low activity, which is slow acetylator, is STAR6, STAR7, and STAR5. Okay, 5, 6, 7. A combination of all these slow acetylator might cause a low activity of NAT2 allele. Okay. Okay, I might skip this one. Okay, now we come to the type B ADR. So this is the one that relates to immunological reaction in which it is not related to the dose or not related to the mechanism of action, pharmacological action of the drug itself. So HLA-induced a severe cutaneous adverse drug reaction. We call it also SCAR, okay, SCAR, SCAR, okay, severe cutaneous adverse reaction. Okay, let's go further. Okay, SCAR reaction. There are several types of SCAR reaction. Examples are Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TEN. I think you have covered this before, but if not, SJS and TEN, it has similar representation, but the difference is the coverage of the body. For example, SJS, it covers less than 10% of the body surface area. So bila kita tengok ni is just less than 10% lah. So that's, we call it as SJS. But TEN is more severe because it involve more than 30% of the body surface area. And in between, for example, 20%, we call it as SJS TEN overlap. So the representation is the same like the detachment of epidermal layer of the skin. Maksudnya dia punya skin tu, mula-mula dia akan start with the mucous membrane. For example, the patient might complain of sore throat ataupun the lips is chapped lips, for example. And also the patient might develop fever as well. So fever is also one of the initial symptom of developing this SCAR reaction. And this patient might develop this between 4 to 28 days after the drug exposure. So it's a bit delayed. Bukannya hari ni dia makan, esok tu terus dapat reaction, tak. So usually it's around 2 weeks until 1 month, the patient will develop this rash. And both conditions are life-threatening and mortality rates are up to 10 to 30% respectively. Okay, so you see dalam 10 orang patient, mungkin 3 orang boleh meninggal, seorang boleh meninggal, okay. And it relates to the this gene. So this is a gene that is the marker for this ADR, which is the HLA gene. So HLA gene encodes for the histocompatibility complex protein, which is involved in the immunological function of the body. It regulates the immune system. So this is the gene, and if you can see here, the HLA gene, they are actually very big. They are class 1, class 2, class 3. And you punya marker of pharmacogenetic marker for ADR is mainly it's HLA-B1502 and HLA-A3101. Dua-duanya dekat class A. There is already a CPIC guideline on the use of anti-epileptics and this pharmacogenetic marker. So if the patient have this marker, for example, if the patient have HLA-B star 1502 positive here, it's either heterozygous or homozygous variant. Maksudnya salah satu sahaja boleh menjadikan patient tu positif. It's either 1502 marker and another allele is different. The patient also considered to be as 1502 positive. Tambah lagi lah kalau dia homozygous. So the patient is considered to be as positive. And negative if the patient do not have this allele at all. Another one is HLA-A3101, also the same. The presence of only one allele of this 3101, this patient is considered to be positive for HLA-A3101. So ini ialah marker kita, okay? HLA-B 1502 and HLA-A3101. So what are the drugs that are related to this ADR and also relate to this, relate to which marker? So actually different drug have their own HLA marker. If you can see here, allopurinol also causing SJS, also causing TN, but the marker is B5801. For carbamazepine, the one that we will see example shortly, mainly 1502, HLA-B 1502, or the others in lah, and also HLA-A 3101. Okay, if you can see here, the first row here and also the last row here. So these two are the only two markers that are included in the guideline. Maksudnya lain tu mungkin tidaklah sampai menyebabkan or recommended to be tested. The one that is recommended to be tested 1502 dengan 3101. And all the other example of the drug lah, dia ada dia punya marker masing-masing. This one is about the anti-epileptic induced CAR and also population. Okay, contohnya for carbamazepine, HLA-A 3101 marker. In the Caucasian, it is related to this SJS10, Japanese, Korean, Han Chinese. And also in 1502, there's also a lot in Southeast Asia. Okay, 1502, Southeast Asia ramai. Han Chinese, Thai, Malay, Indian, Vietnamese, Indonesian, we all have this marker, we all have this indicator that any patient or any individual that have 1502 marker, they are more likely to have this ADR if they are taking carbamazepine. Okay, kalau HLA-A 3101, kebanyakannya mungkin more relevant kepada Caucasian, Japanese, Korean. Okay. And for phenytoin as well, also 1502 in our Southeast Asian and also 1513. Okay, so now we baca case dulu sekejap. There is an example of a case in your e-learn. I put in the learning material. If you can see in the e-learn, okay, go to this topic. And you see here the learning material, the first one here, Bay 2013. Case study, carbamazepine induced SJS. If you can open this and if you can read the case report. Ini sikit je ni, okay? Starting here, okay? Is a 68-year-old male semua ni lah, okay? So baca until this one, the case report punya section. So I give you 5 minutes to read this one first, and then we will answer some question. Okay. Okay, so this case, 68-year-old male presented with left mandibular area pain due to third trigeminal neuralgia. So he had undergone conventional radiofrequency lesioning. Okay, this patient have trigeminal neuralgia and he was treated with carbamazepine 200 milligram 3 times a day, tramadol / acetaminophen combination 3 times a day.
Online lah.
Not
Aku online, tak dapat online.
ya,
Weh, aku silver je kot kat coklat.
Sira. Ada nak tanya apa-apa ke? Okay.
Tak, doktor, okey doktor.
Okay, okay. Alright. So, this patient was treated with carbamazepine, tramadol, acetaminophen, and nortriptyline because of his pain. So, carbamazepine here was indicated also for trigeminal neuralgia. So, not only for epilepsy, but it is still carbamazepine lah, the drug, the same drug yang sama. On his second day of medication, a mild fever and general weakness had occurred. On his fourth day after the beginning of the medication, an oral rash and bullae on the cheek, neck, forearm, and leg were found. On the fifth day, patient visits ER, emergency room, and further history revealed that he had discontinued medication, including carbamazepine 200 milligram 1 year. 200 milligram 1 year previously on his own due to pruritus after taking the medication once. So this is a case of SJS. Ni semua nanti you dah bacakan all these lab parameters, C-reactive protein elevated, potassium elevated, mild leukocytosis. These are actually all the other parameters, clinical parameters that support the Stevens-Johnson syndrome. And carbamazepine was withdrawn and prednisolone was started. So usually the first thing, if you learn in ADR, the first thing that you need to do is you have to discontinue the medication that is likely or possibly caused that ADR based on the previous report. So sepatutnya kita dah tahu, dah boleh agak lah which drug is actually causing that, and we have to discontinue that. And usually for SJS ataupun screen reaction, we give patient with steroid to alleviate the response. Okay, so we give prednisolone 125 milligram per day was started for this patient. And then steroid treatment was given 5 days, gradually withdrawn. Ini ialah presentation of clinical presentation of SJS. Ada subepidermal bullae formation, ada epidermal necrosis. Ini semua ialah presentation of SJS lah. And then dia discharge 2 weeks later. Okay, for this case, the patient is likely to have apa dia? For SJS and carbamazepine. If you can expect lah, based on the previous marker tadi, what would be the marker that is related to this case? Boleh jawab tak? Marker apa? For carbamazepine causing SJS ataupun TN. Patient ni orang Korea. Opa. Seorang opa. Bukan opa, pakcik kan? Okay, what would be the likely marker for this patient? Boleh jawab tak? Do you have any idea? If we can see here. So usually for SJS10 related to carbamazepine, usually the main marker that we would expect, we will test for HLA-B 1502 and HLA-A 3101. So that would be the main marker that we need to test. Contohnya kat sini kan, this carbamazepine 1502 and HLA-A 3101. And if you can see further, this one in Korea ada HLA-A 3101. And also 1502 pun ada juga lah. Usually if it's Asian population, we need to test for 1502. And also HLA-A 3101. Okay, can we answer this question? Okay, true or false? Number 1 and number 2. Number 1, number 2. True or false? Boleh type in the chat. Okay. Number 1 is HLA-B 1502 is a genetic marker associated with significantly increased risk of Stevens-Johnson syndrome in patients treated with carbamazepine. Okay, so this is, number 1 is true, especially for Asian population. Okay, 1502. Number 2, the patient's prior reaction to carbamazepine, which is pruritus, was not predictive of his later severe adverse reaction. Kita tengok, all of you say false. Yes, because the patient actually already have a warning sign. Bukan warning sign jugalah. If the patient actually, when the time or the day that he was being prescribed with carbamazepine the second time, if we are in that situation and we ask the patient whether this patient has taken this drug before, and if the patient told you that, oh, I've taken this before and I got itchiness, so that is already a warning sign that this patient is likely to have this ADR. So means that patient cannot tolerate this drug. So because this drug is causing him to have this immunological reaction in which it can cause a severe type of skin reaction if the patient continues to take it. So if you can see here dekat dalam, so if you can read back this patient tadi, this patient was given the same drug, carbamazepine, twice, but the degree of his cutaneous reaction was greater with the second exposure when he developed SJS. So in his first exposure, dia dah ambil dah 200 milligram, and then second time dia ambil a higher dose. So during the first admission lagi tu, this patient dah already cannot tolerate, dia dah stop sendiri because of the itchiness. That has already should be a warning sign to us lah, yang this patient cannot tolerate and this patient might likely to develop this ADR. And if you can see here, I mentioned before, the first time patient developed that or the first time in which the patient can show the sign is usually around 2 weeks to 1 month, right? But in this case, this patient only on the second day, the patient already have the fever. Fever tu is the prodromal sign lah, maksudnya initial sign this patient is going to have that skin reaction. Biasanya patient dapat fever dulu, ada mouth discomfort in the mouth and in the throat. Maksudnya patient tu develop that signs and symptom earlier because this is actually the second exposure dah sebenarnya. Patient had developed this pruritus before. So that's why the second exposure dia dapat lebih cepat dan it can cause a SJS symptom lebih awal. Okay. So our reflection sendiri as the healthcare provider, if we know if the patient is going to be started with carbamazepine, we should actually ask them whether they have take this medication before, in which sepatutnya kita check lah dia punya marker, okay, because that would be a warning sign. Okay, number 3, ABCD. ABCD, number 3. What would be the best description of the role of pharmacogenetic testing? Yang ni senang je kan. Okay, pharmacogenetic testing could have determined the patient's risk for carbamazepine-induced SJS, supporting a more tailored pain management approach. Okay, yang lain tu salah ke? Salah lah. A, pharmacogenetic testing would have been unnecessary because he had no prior. Salah. B, pharmacogenetic testing could have helped identify genetic risk factor for presenting the need for further treatment. Taklah, sebab kita nak patient tu dapat treatment. Pharmacogenetic testing would have identified other suitable drugs without the risk of adverse reaction. Tak, kurang tepat di situ because it can actually advise for, it can actually guide us for a suitable, but it does not actually predict zero rate of adverse reaction. But it helps us tailor to the best lah. Okay, very quickly, number 4. Which of the following best describe how pharmacogenetic impacts treatment? Okay, Arif dah jawab dah, laju. Okay, it encourages the selection of alternative treatment as pharmacogenetic data can reveal a high likelihood of severe adverse reaction. Okay, so the keyword here as well is the likelihood ataupun probability, possibility. Bukanlah nak kata kita tukar dia punya treatment, memang confirm dia tak akan dapat dah ADR lepas ni, tak juga. It's actually probability. Tapi we try our best to predict what is the best option for the patient. B tu salah lah, kita tak boleh reintroduce carbamazepine or even phenytoin because it has a cross reactivity or cross reaction as well. Yang itu salah lah. Okay. Alright. So ini ialah a summary. 1502, the drugs that are important are carbamazepine, oxcarbazepine, phenytoin. The risk is increased risk of SJS10 and also DRESS. DRESS tu ialah I forgot what is the full term. So it's also related to the skin reaction, but additional to that, it has some, it is a syndrome. Dia ada juga macam a combination of platelet low, for example, and also lymphocyte low. So it caused like a syndrome, including the other clinical parameters as well. So that is stress. Allele frequency banyak dalam, of course, Southeast Asian, Japanese, Korean. Where else? ASH-LAA 3101, among European pun ada, Korean, Latin, Japanese, American as well. Okay. So these are the other two that I mentioned briefly, allopurinol tadi kan. So its marker is HLA-B 5801, also SGS10, and abacavir, which is an antiviral drug, HLA-B 5701. Tapi mainly because our population lebih prone untuk dapat or ada this frequency of HLA-B 1502 and 3101. So it's recommended in our population sebenarnya Southeast Asia untuk check this marker before the patient was started with anti-epileptic of carbamazepine and phenytoin especially. Okay, this is about the cost effectiveness. I think you can read this. Final one. Pharmacogenomics has the potential to reduce the risk of ATR, improve the efficacy, and reduce the cost of healthcare and improve quality of life. Okay. As pharmacogenomics continue to develop, it is important to address the challenges, ensure its knowledge and advancement, and be incorporated in daily clinical practice. So sebenarnya Malaysia has a long way to go. So because this is my last lecture for this paper, so let's hope that when you work soon, we should already have this being implemented, and it has been actually started. And with the My Genome project, the population screening of genome-wide screening for population genetic has been introduced bulan August, I think, in Malaysia. So hopefully kita akan dapat that genome data as a reference in our population so that it will fasten or it will facilitate the implementation of pharmacogenetics. So by that time, hopefully you are ready with our role as a pharmacist, because dekat negara lain, dekat Europe memang dah already being established lah. The pharmacist has taken a very big role because it relates to medication, and you are the best person who knows about the pharmacokinetic, pharmacodynamic, and then you just add some knowledge about genetics, and you boleh actually help the patient and help the prescriber to plan the best treatment for the patient. Okay, so you have a very big role actually in pharmacogenetics. Okay, so that's all. If you have any question, you know how to contact me, email ke, WhatsApp ke. And if you want like a tutorial ke apa, just let me know lah, bagi tahu class track. We can arrange for a tutorial ke, I can give some example ke, question ke, case study ke apa, so that we can work together on that. Okay, all right. So I think that's all from me. So see you in bila ya? Next semester lah kot, I think. Yeah. Okay. All right. So thank you everyone. Bye.
Thank you,